Thank you for having me today. I'm going to talk about the role that radiotherapy has in treating cardiac tumors. I'm a radiation oncologist at Princess Margaret, and I treat sarcomas in addition to brain tumors of all types and also spinal tumors. So what I'm going to talk about today is what the types of cardiac tumors are that are generally treated with radiotherapy. I'm going to talk about how that's accomplished in the modern age. I'm going to talk to the limited data regarding the effectiveness of radiotherapy for cardiac tumors. I'm going to talk especially about the risks and the toxicities of cardiac radiation, because I think that's the most important message, I guess, with regard to the role of radiotherapy is what is the toxicity, and really how do we know of that toxicity and how relevant the toxicity concerns are in today in the modern era, and then by virtue of that, what is the potential future for cardiac radiation and the management of tumors. So which cardiac tumors are treated with radiotherapy? Well, if you're going to go on, what's reported in literature, mostly we're talking about sarcomas. Of course, sometimes carcinomas metastasize to the heart and they can be treated then. Oftentimes there are other tumors like thymomas or mesotheliomas or lung cancers or lymphomas that are very close to the heart or touching the heart, and in that way the heart receives radiotherapy without actually being the target. But personally, the most experience I have is with treating pulmonary artery intimal sarcomas with radiotherapy postoperatively. In terms of the cardiac sarcomas otherwise, what's reported in the literature and what I more know from case reports is people have treated fibrosarcomas, rhabdomyosarcomas, liposarcomas, especially angiosarcomas, etc., all high-grade malignant sarcomas that, for whatever reason, radiotherapy had a role, oftentimes postoperatively, but sometimes as a definitive treatment in combination with chemotherapy, which I'll discuss. So, as I'm sure has been touched on already today, or will be, cardiac sarcomas are rare. Sarcomas in and of themselves are not common, and cardiac sarcomas in particular are rare. So these are not tumors that, in our busy sarcoma practice across the street, we see that often. Among cardiac sarcomas, angiosarcomas are the most common type, and the outcomes generally, although they're rare and it's hard to get great data, the outcomes appear to be worse than for extremity sarcomas, which is what I would expect, at least because the best way to treat an extremity sarcoma is to radiate it and then cut it out. And that's obviously a much bigger challenge in a tumor that's part of the heart. So the toxicities that are associated with cardiac radiation, so if you want to speak generally, the toxicities that we are concerned about when we think about radiating the heart are issues such as pericardial effusion and pericarditis. These are generally late complications, meaning not acute, not subacute, but complications that can occur months or years after radiation, and generally associated with higher doses of radiotherapy. I have 45 gray here, covering a substantial part of the heart. And in fact, the way that we have most of this data, and this is the general theme of my talk, is from our experience decades ago when tumors like Hodgkin's lymphoma were treated definitively with radiotherapy to doses around 45 gray, and cardiac shielding wasn't employed because, in part, the technology was very limited, and in part because there was a lack of understanding about the sensitivity in the heart. And what ended up happening is patients would suffer, unfortunately, from these and other complications. And so I think that probably does a couple things. One, it gives reservation to radiation oncologists and oncologists in general about using radiotherapy to treat cardiac tumors. But it also is valuable data and gives us some idea of what's possible and what's not possible. Because when cardiac shielding began to be used in the treatment of lymphoma, the incidence of these complications was decreased. Now, even in the age of cardiac shielding, before I came to Princess Margaret, I worked at Stanford, and we had a lymphoma clinic, lymphoma survivors clinic. And so we would see patients who were very commonly 20, 30, 40 years out from being treated with definitive radiotherapy for their Hodgkin's lymphoma. And it was very common to see various cardiac ailments associated with that. Valvular disease was very common. For example, and more common, in fact, than, say, pericardial effusion or pericarditis, and heart failure was common too. And the extent to which that was associated with the radiotherapy is hard to say, but I'm certain there is a link because radiation is toxic, and including to muscle. We know a little bit more about ischemic heart disease, specifically, actually, from the breast cancer experience. Interestingly, in the modern era, breast cancer is treated with tangent fields that minimally irradiate heart tissue. But particularly for left-sided tumors, the heart will get a small amount of dose. In fact, we now have technology to limit even that with respiratory gating, for example. But still, the heart does get some dose. And in decades past, when that was less understood, a substantial proportion of breast cancer patients developed ischemic heart disease as a result of their radiation. And there are certain what we call constraints in the radiation oncology world associated with heart irradiation based on the experience of breast cancer treatment, which is not relevant to a discussion of cardiac tumors per se, because they're very, very low. So we're talking about breast cancer patients who we fully expect to cure. Radiation to the breast is part of that cure, but it can decrease their survival ultimately by increasing their risk of ischemic heart disease. So not relevant necessarily to a discussion of cardiac tumors, but still just further evidence that radiation isn't good for the heart, and we should avoid it when we can. But it's not doesn't necessarily mean that radiation doesn't have a role in the treatment of cardiac tumors. As I was saying, congestive heart failure is a potential late complication of radiation, again, in, for example, survivors of Hodgkin's lymphoma and valvular disease, as I said, is something I commonly saw. I've seen quite often in Hodgkin's survivors. So how are cardiac tumors treated in the modern era? Well, for example, when lymphoma was treated even a few decades ago, it was radiation from the front, radiation from the back, or maybe potentially even just from the front. Full dose to the heart. There's no possibility with that level of technology to spare what are known to be sensitive tissues. But in the modern era, our imaging is much better, and the technology we have to deliver radiotherapy is much more sophisticated. And so we can do things like this image you see here with multiple beams that are modulated individually. The beamlets within those beams are modulated individually such that you can sculpt dose in a very specific way around the tumor, sparing aspects of the heart which you do not wish to irradiate. And coupled with that, of course, we have improved imaging in the form of nuclear scans and MRI, which allow us to see better what exactly it is that we're trying to treat. And the combination of improved imaging and the improved ability to deliver radiotherapy very conformally means that, the cardiac radiation in 2020 is very different than it has been historically, and it's much more conformal and therefore much less toxic, and toxic probably in different ways. So I just want to give you an example of how we might approach a case of a cardiac tumor in the modern era with radiotherapy, avoiding as much as we can in this case for this tumor, which was mainly superior, avoiding the ventricles, which which we know will be affected primarily with the radiotherapy. So we have very good imaging, in this case a contrast-enhanced CT scan, and we basically go slice by slice, identifying exactly where we feel the tumor is. And if we had a cardiac MRI, for example, we would register those images to the CT scan and do the same thing. So we map out where the tumor is. We do that generally on axial scans, but we can do it on coronal images or sagittal images as well. And then we ask the computer essentially to apply dose to that structure in the most conformal way possible, avoiding other structures. And this is sort of like what a dose distribution might look like. And you can see, for example, that on this axial image, it's carved around the spinal cord, because the spinal cord is even more sensitive to radiation than the heart is. So in the modern era, radiation is delivered almost uniformly now in this type of case with what's called arc therapy, which means that the gantry of the linear accelerator spins in a 360-degree arc around the patient, delivering radiation continuously. And that just allows us to deliver the radiation more efficiently and also to be highly conformal. So what does the computer see? It basically sees this target with a little bit of an expansion on it. So this blue thing is the actual target volume. These little lines, by the way, represent the amount of dose which is coming through particular angles. So in this case, you can see that most of the radiation is actually coming from the front and the back, but some is delivered to the side as well. And so here's the target volume. Here is the spinal cord, the lungs, the esophagus, and the left ventricle, and that's what those were the organs we were trying to avoid. Now, in terms of what's been published, very little has actually been published on the effectiveness of radiotherapy. So you can see here that this is a case report of a patient with angiosarcoma of the heart who was treated, I believe, at a Japanese center with a combination of radiotherapy and chemotherapy. So this patient was treated with weekly carboplatin, paclitaxel, and 60-gray radiotherapy, a very high dose, a dose, in other words, much higher than what we know to be potentially toxic to the heart for right atrial angiosarcoma, which was already metastatic to the lungs. And as much as this is obviously an incurable situation, there was a significant reduction in the size of the tumor before and after treatment. This is another case, similarly, of a 37-year-old woman with right atrial angiosarcoma who was treated with a similar dose, 55.8 gray, and weekly paclitaxel. This is the image that I stole, showing you how, in this case, IMRT is delivered for this tumor. And you can see, again, substantial reduction in the size of the tumor, showing that, radiation in combination with chemotherapy is a very effective way of treating this malignancy. This was an interesting case report, I thought, because it's a tumor which we don't typically consider to be highly radiosensitive, UPS, of the left atrium in this patient. This was another Japanese case report, and this particular patient had had, I think, 2 or 3 surgeries and then a mitral valve replacement. But unfortunately, imaging revealed further recurrence of the tumor, and the patient was treated with radiotherapy alone and had a very good response to that. So even a tumor like UPS can be potentially targeted with radiotherapy and a life-extending treatment. The final case report I just wanted to highlight was published just last year. A young woman with a right atrial angiosarcoma, again with lung metastases, treated with very hypofractionated radiotherapy, 30-degree and 5 fractions. The thing about radiotherapy is that the larger the fraction size, it's not strictly a quantitative thing. So in the previous reports we saw 60 gray and 30 fractions. This is 30 gray and 5 fractions. So they're bigger doses of radiotherapy with each fraction. And when you do that, the radiation can be more effective, particularly for a slow-growing tumor like a sarcoma. At any rate, this case was a good one because they discussed the use of four-dimensional CT scans and fluoroscopic guidance during imaging. And so we're able to use this very hypofractionated approach to deliver highly conformal radiotherapy and rescue this woman from her hemodynamic crisis, at least temporarily. The final thing I wanted to discuss, this is in the vein of the future potentially, or one of the potential futures for cardiac radiotherapy, was this interesting report from the New England Journal published a couple years ago now from work done at WashU of patients who had structural heart disease and had ventricular tachycardia from that. And I don't know how many people in the audience, perhaps several, are familiar with this paper, but at any rate, the essence of this work was that they used they were able to map the circuit of the VTAC, correlate the suspected site of that using MRI and SPECT, and then irradiate that site to correct the VTAC or decrease the number of events by almost 100% in 5 patients. So this was something that had been reported in a few case reports previously, but this was the first well-done study of this and created enough of a splash to be published in the New England Journal. So this is some of the images they showed, the VTAC episodes with a sharp decrease, ICD shocks and sharp decrease, and then just a little bit of the imaging that was used to identify the scar, which was then targeted in one particular patient. So to conclude, I guess the messages that I would like to come across from this talk are that really any malignant tumor, primary or metastatic to the heart or adjacent to the heart, can be treated with radiotherapy. And it can be done safely in the modern era, and we have a fairly good understanding of what the risks are, both in the short and long term, with that approach. Modern techniques in radiotherapy are very different than what was done even a decade ago because of issues such as image guidance that are improved, respiratory gating, and the use of more sophisticated ways of technologically delivering the radiotherapy. There are multiple case reports describing effective treatment of cardiac tumors with radiation. There's very few, or if any, large-scale studies specifically looking at cardiac sarcomas. And the risks of cardiac radiotherapy are well characterized and can be largely avoided using modern techniques.